Hi everyone, my name is Kale. Today I'll be talking to you about impotence or erectile dysfunction. Those are two terms just meaning the same thing. We'll be covering the anatomy and the physiology of an erection, what's actually involved and in it. We'll go through an overview of erectile dysfunction. We'll go through the causes, how to take a clinical history and do an examination. And finally, we will speak about some of the treatment options. Let's start with the anatomy of the penis itself. The structure of the penis is split into three parts: the root, the body, and the glands, as you can see in the pictures to the right. The root is the most proximal part of the penis. It is fixed. It's containing three erectile tissues, the two crura and the bulb of the penis. If you look at the picture on the bottom, the two crura are there in green. The bulb is in yellow. Now all of this, the root is contained within the superficial perineal pouch, and this is generally within the body itself, so it's not external, it can't really be felt. The body of the penis, this is distal to the root. This is the free part between the root and the glands. These are also composed of three cylinders of erectile tissue: the two corpora cavernosa and the corpus spongiosum. Again, if we look at the picture on the bottom, the corpus cavernosa and the corpus spongiosum are continuations distally of the two crura and the bulb. Finally, we have the glands of the penis. This is the most distal part, the head of the penis itself, and this is formed by the distal expansion of the corpus spongiosum. Again, that's expressed here in the bottom picture. The urethra of the penis is within the corpus spongiosum. Now you can see that in both the top and the bottom pictures. The urethra is central within the corpus spongiosum. When I say erectile tissue, and we're talking about erectile tissue, if we look at the bottom picture, you'll see the cross section. You see these two green circular structures. These are the corpus cavernosa, and they're erectile in that they have caverns in them, as it's called cavernosa. Caverns or sinuses, little sinusoidal spaces, and these fill with blood within the erection, and that's what causes them to erect. They're like balloons. Okay, let's talk about the arterial supply. The arterial supply comes from the internal iliac artery, which then goes into the internal pudendal artery, and then we go into the specific arteries of the penis itself. We have the dorsal arteries of the penis, the deep dorsal artery of the penis, and the bulbourethral artery of the penis. I've included these pictures here because I think shows them best. Let's look at the top picture. We have the dorsal artery. These are these two paired red structures on the dorsal aspect of the penis, on both the left and the right of the midline deep dorsal vein. Those are the dorsal arteries. We also have the deep dorsal artery of the penis. It's not in the top picture, but it's in the bottom one. Those run centrally within the corpus cavernosum. Again, if you look at the corpus cavernosum, those two circular cavernous spaces, at the center of those you have what's called the deep dorsal artery of the penis. Another name for that is the cavernosal artery. These are the arteries responsible for the erection. Finally, you have the bulbourethral artery. Again, in the bottom picture, if you look at the urethra itself, within the corpus spongiosum, you have two bulbourethral arteries there. That's the arterial supply. Then you have the venous drainage. Again, you have three veins involved. You have the deep dorsal vein, the superficial dorsal vein, and the circumflex veins. If we look at the bottom picture, you have the outer layer of the penis, the dartos fascia. Deep to that is the superficial dorsal vein. Deep to that you have the buccal fascia, and then deep to that we have the deep dorsal vein. That's the main vein, the midline structure on the dorsal aspect. And coming off the deep dorsal vein, you have these circumflex veins, which are circumferential around the penis that supply venous drainage. And these circumflex veins also penetrate into the corpus cavernosum and drain the corpus cavernosum. Finally, you have innervation of the penis. S2 to S4, those spinal segments and the associated spinal ganglia is where we get penile innervation. The penis has both sympathetic and parasympathetic innervation. The sympathetic innervation to the skin and glands is supplied by the dorsal nerve of the penis, which is a branch of the pudendal nerve. If we look at the bottom picture, you have the deep dorsal vein, that central structure. Lateral to that on both the left and the right, you have the the dorsal arteries. And then lateral to that, you have again the paired structures, the dorsal nerves of the penis. Now, that is a sympathetic supply. It gives the sensory innervation to the penis. That's what senses touch and pain to the penis itself, and is a branch of the pudendal nerve. The parasympathetic innervation is important in the erection. It is carried by the cavernous nerves. If you look to the picture at the top, there's a behind the root of the penis, you see like a mandarin-like structure, and it's sitting in a blue basket. That mandarin structure is the prostate, and that blue basket it's the periprostatic venous complex. We have, if you see lateral to that, you have the cavernous nerve in that picture. The cavernous nerve, that contains the parasympathetic supply to the penis. That runs, if you follow it, it goes deep into the corpus cavernosum itself, and that is in control of the vasodilation of the deep dorsal artery. So the parasympathetic supply through the cavernous nerve causes the vasodilation of the deep dorsal artery, which increases blood supply to the corpus cavernosum. That's important to know. That cavernous nerve and its anatomy is important to know, being quite intimate to the prostate. In radical resection of the prostate, those nerves are the ones that are easy to damage because they're quite adherent to the prostate and the prostatic fascia. So when it's removed, and if those nerves are damaged, these patients can have erectile dysfunction. Okay, that's an anatomy. Let's go through the physiology of an erection itself. Okay, an erection is the enlarged and rigid state of the penis. It's needed for sexual intercourse and is caused by the engorging of blood, specifically within the corpus cavernosum. There are three contributors: the neural supply, the vascular supply, and a hormonal influence. We'll go through all three of those briefly. The neural supply of the penis affords two types of erection, I guess. There's the psychogenic and the reflex erection. I've included both of these here and just a brief summary of their pathways. and the picture on the right goes through it as well. So a psychogenic erection, that's caused by erotic stimuli, be that an image, anything that a man would find sexually exciting, that even a thought, both those are centrally perceived. If we see in the image, that is then sent down descending autonomic pathways down to T11 to L12. Now this is the thoracolumbar erection center. This synapse is there, and there is parasympathetic stimulation. If we follow this photo, parasympathetic stimulation carried along the cavernosal nerves, and then causing arterial vasodilation. So that's the psychogenic neural pathway. Then we have the reflex pathway. This comes about through tactile stimuli. So again, if we look at the picture on the right, down the bottom left corner, we have tactile stimuli. That's to any touch of the penis itself or the surrounding thigh. The mechanoreceptors are stimulated, and there's a reflex arc that happens through S2 to S4, which is the sacral erection center. That gets activated or excited, then goes back through the pelvic plexus, the cavernosal nerves, and then again causes arterial vasodilation. So these are the two aspects. So if a man has sexual thoughts or sees something erotic, he will have an erection. If a man's penis is touched, he will have an erection. Those are the two different pathways. So what happens when these how does these parasympathetic nerves cause vasodilation? This is a good image that explains it. We'll start at the top left. You see parasympathetic nerve fibers. Those release acetylcholine. Acetylcholine binds to the muscarinic receptors within endothelial cells and activates nitric oxide synthase. This is an enzyme that causes the synthesization, is that a word, of nitric oxide. Nitric oxide promotes cyclic GMP, and cyclic GMP causes a reduction in calcium and therefore vasodilation of smooth muscle. So nitric oxide promotes cyclic GMP. Cyclic GMP relaxes your smooth muscle. So this is all within the intercavernosal space. The next slide explains that a bit more. Let's look at the picture on the left. The picture on the left, again, is the anatomy of the penis. The box within it that says erect, this is what happens. That central artery is the deep dorsal artery. As nitric oxide is synthesized, increases your cyclic GMP, it causes vasodilation of that artery. We see that it's expanded here in this picture, where in the erect box, that artery is expanded, and so are its arterioles. So you have an increase of blood supply into the corpus cavernosum, and you see these sinusoidal spaces. These are these purple pouches, and as the artery dilates, the blood flow to those sinusoidal spaces increases as well, and so it blows up and expands like a balloon. So that's for the erect. You see the difference with the flaccid box, the central deep dorsal artery, or cavernosal artery, that's quite constricted. Because it's quite constricted, the sinusoidal spaces are not as expanded. The same happens if you look at the venous supply. Let's look at the erect box first. The venous supply in the erect box is quite collapsed. That happens because of the pressure of the arterial system. It causes the collapsing of the venous system, reducing the venous drainage. And that's the opposite there in the flaccid section, the flaccid box, where because there's less pressure within the corpus cavernosa, the veins, the deep dorsal vein and circumflex vein are draining the corpus cavernosa quite well. Now the picture on the right, I think, is just the same representation. You see on the top where it's flaccid, the deep dorsal vein, that central dorsal vein, is expanded and quite large, causing increased drainage. In the erect one, below that, again, that deep dorsal vein is more compressed. If we look at the arterial structures in the picture at the top, the cavernous artery or the deep dorsal artery is compressed or constricted. On the bottom picture in the erect one, it is dilated. So that's the vascular contribution to the erection. Finally, you have the hormonal input. For erections, testosterone is vital, and testosterone has multiple effects in the control of erections, both centrally and peripherally. So centrally, it increases a man's libido, that's his sexual drive, and also his sexual behaviors. It increases those. Peripherally, it's involved both in the growth, the differentiation, the maintenance of the penile structure itself, but also, and most importantly, testosterone promotes nitric oxide synthase. If you remember nitric oxide synthase from a few slides before, nitric oxide synthase increases or causes this the creation of nitric oxide. Nitric oxide creates or increases cGMP, which causes vasodilation. So testosterone is critical for that. But testosterone also has an inhibitory effect on PDE5. PDE5 is phosphodiesterase 5. And what that does is it decreases cGMP. So by decreasing, a lower amount of cGMP will lead to a lower amount of vasodilation, which a lower amount of vasodilation will lead to less blood in the penis, which means less erections. So testosterone increases nitric oxide synthase, which is good for an erection. It decreases PDE5, which is also good for an erection. Now just remember PDE5 because we'll come back to that when we talk about treatments, because that is acting upon phosphodiesterase 5 and inhibiting it is critical in the treatment of erectile dysfunction. Okay, so that's an overview of the physiology. Let's go through dysfunction, erectile dysfunction. So the definition is a consistent or recurrent inability to acquire or sustain an erection of sufficient rigidity and duration for sexual intercourse. This can be both primary or secondary. Primary is since puberty and is quite rare. That is when a young boy going through puberty and becoming a teenager is just never able to have an erection. The secondary one is a lot more common, and that's where men are able to have adequate normal erections until a certain time, and then that stops. So that's a lot more common. And erectile dysfunction is the most common cause of sexual dysfunction. So more common than issues with libido, more common than issues with ejaculation. Erectile dysfunction is the greatest cause of sexual dysfunction. It's quite common. 40% of 40-year-olds will have erectile dysfunction, and that goes up by 10% each decade. So it's easy to remember that 50% of 50-year-olds will have it, 60% of 60-year-olds. So by the time an 80-year-old man comes to see you, 80% of those men will not be able to have, will be having erectile dysfunction. Now let's go through some of the causes. So how do you take a history for a patient that comes in to see you in a GP practice with erectile dysfunction? Then it's important to take a solid sexual history, and you'd want to know the onset and duration of the problem. So is this a new thing? Did this start recently, or has this been going on for years, or have you never been able to have an erection? That's it's important to differentiate. Like we started with either primary or secondary erectile dysfunction. You'll need to know when it actually started. If they've had any other previous treatments for it, the rigidity and duration of both sexually stimulated and morning erections. Are there any other problems with the patient's sexual experience, including arousal, ejaculation, and orgasm? Are those affected? It's important to know because sometimes it's in explaining erectile dysfunction, a man may mean something different to what you are wanting to understand. So it's good to clarify all of these things. Also, current relationship status and contextual threats. For example, I've included, if this doesn't get better, we're over, or if this doesn't get better, I'm leaving you, or this relationship's finished. All of those kind of relationship stresses, but also work stresses, other anxiety and mental health is good to explore. Furthermore, any history of previous sexual partners and relationships. Is this an issue that happens with just a single partner or with all partners? If the patient shares that with you, it's important as well. And then issues of sexual orientation and gender identity. You want to go through the patient's lifestyle factors. And this is to elucidate their risk profile. So cigarette smoking, any other drugs that they're taking, cocaine. Cocaine can cause erectile dysfunction, so a recreational drug profile is important to know. But then just the other general health and lifestyle baseline is important to know. And then finally, a concurrent medical history, again, to assess their risk. Did I miss anything? And then, lifestyle factors. Okay, how would you examine for erectile dysfunction? It's mostly you're not going to find anything too obvious. If you see something like on this picture on the right, Peyronie's disease, which is a fibrous plaque within the corpus cavernosum, which causes a structural abnormality, that can be an obvious sign. But besides that, you may not see anything besides what you may pick up as risk factors. So in general appearance, is the patient morbidly obese? Does the patient otherwise look fit and healthy? Doing a neurological exam, a vascular examination, again, those just to get a broader understanding of the patient's health. Then there's penoscrotal abnormalities, specifically, like I said, the penile plaque or Peyronie's disease, but also penile size and hypogonadism. These can be indicative of a lack of androgenization, so a reduction in testosterone level in a patient. Size and hypogonadism, so that's the size of small testicles. That can be an indicator of a low testosterone level. So how would you investigate? Generally, again, there's not much you need to do to investigate specifically, but you can screen for other diseases. Again, you look for your testosterone level. You want to know what's this patient's fasting glucose. So are they a diabetic? What's their lipid profile? What's their risk? So their heart disease risk. Also their hormone profiles. And then a PSA. A PSA may not be necessary, but if they are an elderly man, let's just say above his 60s, and has concurrent lower urinary tract symptoms, a PSA may be a consideration as well. Now let's just go through briefly the treatment of erectile dysfunction. There's quite a lot that we can do, and a lot of it is pretty intuitive. So your lifestyle changes, diet, exercise, smoking, and psychological aspect of it as well. Counseling, that's important for the patient, but also the patient's partner. The anxiety involved in the relationship, in the sexual aspect of the relationship, this can have a significant impact on the relationship itself when their sexual life is diminished. So that's important to consider and to open a healthy discussion with your patient so that that's not ignored and the emotional aspect isn't discredited. You also want to optimize their other medical conditions, make sure their diabetes is under control, get them on a statin to lower their lipid profile, control their blood pressure. If their testosterone is low, you can contribute, you can help that as well. So those are the baseline things that you want to do, but then there's more specific treatments. So you can have an oral erectogenic. Now we talked about PDE5. So just a refresher, PDE5 decreases your CGMP, and CGMP is important for vasodilation. So if we inhibit PDE5, that will increase your CGMP and increases CGMP-mediated nitric oxide vasodilation. So that is the main oral erectogenic that we use. The most common is sildenafil. Sildenafil is also called Viagra, and this is you still require sexual stimulation. So it's not that you just take this tablet and you automatically get an erection. You still need to get some sort of sexual stimulation, and about 60 to 70% of patients will have some benefit. So generally, they tell patients take the tablet about an hour before you conceive that you'll be having sexual intercourse. Take it on an empty stomach. That's how it works. And about 60 to 70% will have some benefit with it. Then you have injectable erectogenic. So it kind of works in a step-by-step process. If the oral isn't working, then we can use injectable erectogenics. So this is where the patient will self-inject into the corpus cavernosa alprostadil, which I guess is similar to the PDE5 inhibitors, or they're vasodilators. You inject into the corpus cavernosa itself. About 80 or 90% will have benefit with this as well. But again, there's significant barriers. One, it can be painful. Men can be quite uncomfortable with injecting into their penis. But there's also bleeding and infection and the education for the patient itself. So that can be a bit of a barrier. Then we have, if those don't work, then we suggest vacuum pump devices. These can be very effective and they're pretty cheap to use. So the vacuum pump, if you look at this picture, the vacuum pump goes over the penis itself. It's a plastic cylinder and it causes negative pressure. You pump it and it draws blood into the penis, causing it to erect. At that point, you put there's a firm rubber ring that is applied to the base of the penis, and it stops the venous outflow. At that point, you have an erection and can have sexual intercourse, and then you would have to remove the rubber ring. So that's also an effective way. Now, if none of those are working, there is this final option, and this is an inflatable penile prosthesis. This is a surgical procedure. Definitely a urologist will be well involved. This includes, there's three parts to it. There's these long cylinders. The cylinders are like a replacement of the corpus cavernosa. Then you have a reservoir, which is a reserve of saline, and you finally have a pump. The cylinders go into where the corpus cavernosa would be. The reservoir sits up near the bladder or next to the prostate sometimes, and then the pump itself sits in the scrotum or on the thigh, just depending. And what happens is when a man wants to have sexual intercourse or have an erection, he'll press the pump or pump up the bulb and pump up the bulb, and what will happen is the reservoir of saline will fill into those cylinders and erect the penis, and then when he's complete or when he's finished, he will release the valve and the saline goes back into the reservoir. Now this is again effective, but this is when other methods are no longer working. So that's a bit of an overview. I've got just go through, these are my references here. That's a bit of an overview of erectile dysfunction. I hope you've learned something, and all the best. Thanks, guys.